Good morning, everyone. Today I will be presenting a presentation on Pimavanserin. It is approved for the treatment of Parkinson disease psychosis. I am Dr. Neal, Junior Resident, SMC and CSSH, Meerut. This is our basic outline that we are going through. Now, what basically is Parkinson disease? It is a chronic progressive neurodegenerative disorder. Degeneration of dopaminergic neurons is seen in the substantia nigra. So that is the basic brain area that we have to pay attention to. It leads to dopamine deficiency in the basal ganglia, which plays a key role in regulating movement, and Lewy bodies abnormal aggregates of the protein alpha nuclei is also seen. So these are the basic dopaminergic pathways seen in the brain. We basically have to pay more attention to the nigrostriatal pathway, starting from the substantia nigra to going to the basal ganglia ka striatum part. So your green wala dopamine pathway that is basically associated with. So these are the structures that we were talking about. You can see the substantia nigra, and then you have the loss of dopaminergic neurons, which leads to Parkinson's disease. Etiology, there are various genetic and environmental factors. You also have the accumulation of certain proteins. Risk factors is advanced age, family history. In males, it is around 1.5, 1.6 times more compared to females. Head trauma, emotional stress and personality, and depression. Parkinson disease, you have your motor symptoms and non-motor symptoms. The thing is that your non-motor symptoms occur much before your motor symptoms. So paying attention at the non-motor symptoms, especially in the aged population, gives an indicator of a fact that Parkinson's disease might be incoming. So if you have an elderly reporting loss of smell, constipation, cognitive impairment, or sleep disorders, then this cluster of symptoms could indicate an impending Parkinson disease in the near future. Again, non-motor symptoms just explained a little better: mood disturbances, cognitive, psychotic symptoms, sleep disturbances, autonomic dysfunction, sensory disorder. These non-motor symptoms are basically present more when the disease has already occurred. And the one on the slide before were the cluster of symptoms that occur before the Parkinson's disease develops. Now we come into Parkinson disease psychosis. Now, because of loss of dopaminergic neurons, you have a decrease in dopamine, which leads to a lot of your motor dysfunction. Whereas in psychosis, to counteract psychosis, we again have to decrease the amount of dopamine. So this becomes a little bit problematic when we are dealing with Parkinson disease psychosis. Around 20 to 40% of people with Parkinson's disease will have symptoms of psychosis in the early stage of disease, and up to 70% people will experience psychosis. Now, the fact is that once you have psychosis in Parkinson's disease, your mortality rate increases significantly. Therefore, managing psychosis in Parkinson's disease is an essential thing. We had seen this slide before, wherein we had compared how the psychotic symptoms are occurring. We can see the glutamate pyramidal neuron. Serotonin is the positive, GABA interneurons is the negative. Now what happens in Parkinson's is कि जो तुम्हारा substantia nigra है वहां पे तुम्हारे डोपामिन लॉस होगा और रैफे न्यूक्लियस में डोपामिन लॉस होगा. उसकी वजह से there will be compensatory hypersensitivity of your serotonin neurons over here. So even a small amount of serotonin will trigger a greater response compared to your normal. Normal we had dealt, serotonin becomes your positive, this becomes your negative terminal. This is what the basic glutamate pyramidal neuron is. यहाँ से पॉजिटिव हुआ साइकोटिक सिम्टम्स ज्यादा आएंगे, यहाँ से नेगेटिव हुआ तो साइकोटिक सिम्टम्स ज्यादा आएंगे. उसका बैलेंस हमको मेंटेन करना होता है. Here because of loss of dopaminergic neurons in the raphe, उसकी वजह से यहाँ पे हाइपर सेंसिटिविटी हो रही है 5-HT2A रिसेप्टर्स की. अभी ये हाइपर सेंसिटिविटी की वजह से क्या होता है कि थोड़ा भी सेरोटोनिन आके साइकोटिक सिम्टम्स कॉज कर देता है. डिमेंशिया में जैसे पार्किंसंस में सेरोटोनिन में इफेक्ट हो रहा है, डिमेंशिया में जो नेगेटिव होता है वो रुक जाता है. So I've just given this slide if you want to look at it later. Diagnosis के लिए we use a lot of laboratory tests. We use MRI, brain imaging, to see what areas of the brain is getting affected, and we should also review what medication the patient is on, and the alternative causes of psychosis and Parkinson's should also be considered. These are the potential causes of acute psychosis, and then the investigations. Vascular होगा, infective हो सकता है. Certain toxins like alcohol and substance abuse also cause psychotic symptoms. Metabolic disorders हो सकता है. Neoplastic हो सकता है. Frontal lobe tumor हो सकता है. So according to that, we will also get all the investigations done to rule out that the psychosis is occurring due to Parkinson's disease and not due to some other factor. Once we are sure about the fact that it is Parkinson's disease psychosis, PDP hai, then we can then look on to the treatment options. So identification and removal, if we have found a secondary cause, so we will remove that. Then we will modify our treatment that we are given for Parkinson's disease, and then we will use anticholinergic amantadines. These are again given but no more used as such. Currently, what we see in clinical practice getting used most is your atypical antipsychotics, quetiapine and clozapine being the two main thing that we use for Parkinson's disease psychosis. A lot of cases that I've seen in OPD of Parkinson's disease developing psychosis, usually in the 65 to 70 age group, have been managed with quetiapine somewhere ranging from 50 to 100 mg. So anywhere ranging from 25 to 150 is the range of quetiapine that has been given for managing PDP. Again, for quetiapine, it offers rapid response, does not require frequent blood monitoring, and maximum use of antipsychotics is because of lack of approved medications. So quetiapine has its merit. It also has its demerits. As we know, it is a very sedative molecule. So in elderly, there is a risk of fall, fracture, all of these things. So we have to manage sedation. Quetiapine is a very sedative molecule. So use is a little problematic, and also it causes QT prolongation. This is the basic structure of quetiapine. As we can see, the D2 efficacy of quetiapine is quite low compared to the 2A one. So this is what we need to attack. We will basically be focusing on 2A. 5-HT2A को हमको antagonize करना है या inverse agonist use करके रोकना है. So we want to see molecules which have good potency for 5-HT2A but very low potency for D2. So quetiapine becomes one of those molecules. Second one is clozapine. One of the highest data that we have is for in PDP is for clozapine, but again clozapine has its side effects, so we have to be very careful when using clozapine. Again, clozapine mein we can see that the 5-HT2A that has been highlighted over here is pretty far off from D2, and D2 भी काफी end पे है. So उसकी D2 का जो efficacy है वो काफी कम है compared to 5-HT2A. So again, this makes clozapine a good molecule. Here all of the pines are there. Pines ही होते हैं molecules जिसमें 5-HT2A अच्छा दिखता है and D2 थोड़ा lower efficacy में है. So if you look at all the pines, you will see that end में D2 is present in quetiapine and clozapine, whereas for olanzapine and all, it has good D2 receptor affinity. So because of that, quetiapine and clozapine becomes the two molecules wherein you have low propensity for D2 also and high propensity for 5-HT2A. So that's why clinically these two have been used. Now moving on to the target molecule, Pimavanserin. As you can see, Pimavanserin का receptor profile बहुत ही simple है. It is basically 5-HT2A and 5-HT2C. 2A is much larger. As you can see, the size of the 5-HT2A given over here is much larger compared to 2C. It is around 40 folds and it has no D2 affinity. Thus, we do not have to worry about the fact that a molecule will reduce the dopamine, then again worsening the Parkinson's disease ka motor symptoms. Only the psychotic symptoms are handled over here. Also, it has FDA approval in 2016 for management of delusions and hallucinations in Parkinson's disease psychosis. Mechanism is 5-HT2A का inverse agonist है. Agonist is positive, antagonist is 0, inverse agonist is negative. So it will cause a opposite effect on the receptor. तो 5-HT2A का जो एक्शन है उसका अपोजिट इफेक्ट करेगा वो. So inverse agonists have the opposite effect of antagonist on intrinsic activity in contrast to blockers or antagonists which block the effect of agonist but have no inherent impact of their own. High doses of pimavanserin lead to the recruitment of 5-HT2C receptors after the saturation of 5-HT2A receptors. Pharmacokinetics, Tmax is around 6 hours, ranges from 4 to 24. Highly protein bound, 95% of it is protein bound. Predominantly metabolized by CYP3A4. So all of your inhibitors of 3A4, if you are giving them, then you have to reduce the doses of pimavanserin because blood concentration of pimavanserin will increase. All of your azoles, ketoconazole, all of these drugs are very strong inhibitors of CYP3A4. So we have to pay attention whenever we are giving these substances, these drugs, we have to decrease the quantity doses of pimavanserin. Half-life, plasma half-life is around 57 hours and जो उसका मेटाबोलाइट है उसका around 200 hours है. Clinical evidence, we will gross through this. The first one that they have done is basically comparing pimavanserin 34 mg to quetiapine 25 or 50 mg. This is basically comparison of two molecules, quetiapine and pimavanserin, and they are seeing if pimavanserin is actually effective. They used SAPS PD scores and CGI scores. The result that they have found is that pimavanserin is much effective compared to quetiapine at 25 mg and 50 mg. The second study that they did was for pimavanserin in patients with psychosis and Parkinson's disease, that is your PDP. It is a 6-week trial and this was done against a placebo. So the first one was a non-inferior trial wherein they are saying that pimavanserin is not inferior than quetiapine, and this second one they are comparing it to placebo to show that pimavanserin is effective. What has been found is that pimavanserin shows benefits to symptoms of psychosis through 3 independent measured outcomes in addition to secondary outcomes including sleep and caregiver burden, as well as no association in regards to exacerbation of motor disability, sedation or other safety challenges. So sedation is one of the main problems that we have been dealing with quetiapine and clozapine, and the pimavanserin molecule does not cause a lot of sedation. Comparison of pimavanserin versus quetiapine for hospitalization and mortality risk. Basically, they took all the Medicare patients, not all, a certain percentage of Medicare patients, and they tried to compare if compared to quetiapine, what is the hospitalization and mortality risk. Again, it was seen that risk of hospitalization was lower in pimavanserin users compared with quetiapine, and no difference in mortality was observed between pimavanserin and quetiapine. Long-term evaluation, this is basically for safety and tolerability in Parkinson's disease psychosis. They have found that long-term management with pimavanserin 34 mg once daily demonstrated a favorable benefit-risk profile with no unexpected safety concern. Mortality rates suggest no increased risk following long-term treatment. Now, pimavanserin does have a black box warning label on it. It is because of the basic group that it belongs to. In majority of the trials that they have found no increase in mortality risk when pimavanserin is added in Parkinson's disease. Whereas if you take quetiapine or clozapine, there is up to 2 to 4 folds increase in risk of mortality when you add these antipsychotic medications. Therefore, as a class label, the black box warning has been set on pimavanserin, but no absolute study has proven that there is a mortality risk significantly increased in pimavanserin. Motor and cognition related safety, again, it is not affecting D2. So we already can say that motor and cognition पे ज़्यादा effect होगा नहीं उसका. Pimavanserin 34 mg was well tolerated and did not yield a negative impact on motor or cognitive related functions in patients with Parkinson's disease psychosis. Basically, all of these studies are just proving the theory that we have seen till now. Nighttime sleepiness and daytime sleepiness improve with pimavanserin during treatment of Parkinson's disease psychosis. Results do not suggest an increased risk of falls or fractures among patients with PDP taking pimavanserin compared with those taking other atypical antipsychotics, and sensitivity analysis suggests a decreased risk of falls and fractures. So again, with quetiapine and clozapine, because of sedative ability, you have increased risk. So pimavanserin does not show any of those. Comparative efficacy, safety, acceptability of pimavanserin and other atypical antipsychotics. This is a meta-analysis that they have done, systematic review and meta-analysis of the 19 unique studies, which included around 1242 patients. So this becomes a significant study. Pimavanserin and clozapine demonstrated significant improvement in psychosis without affecting motor functions. Now, though it was not mentioned over here, if you deep dive into the study, pimavanserin and clozapine में दोनों में no molecule has come out as superior when it comes to the effect or reduction of psychosis in PDP. But clozapine inherently has a lot of other side effects, because of which pimavanserin then becomes the better molecule. So here they have not mentioned that pimavanserin is better in reducing psychosis. Although clozapine also improved symptoms of psychosis and did not worsen PD's motor function, it was more likely than pimavanserin to be discontinued due to adverse effects, and it required intensive ANC monitoring. Effect of treatment with pimavanserin of activities, basically daily living better हो रहा है नहीं हो रहा है. Findings highlighted the potential for improvement in functions and with improvement of psychosis symptoms in patients with PDP, and suggest that mean FSQ may be a measurement tool to evaluate the level of improvement in functions. So these were all the studies that basically proved all the theory that we had seen. Prescribing information 34 mg hai once daily without titration. Pimavanserin can be taken with or without food. There's also a 17 mg available to be given in the CYP3A4 inhibitors. Pimavanserin capsules can be taken whole or opened, and the entire contents sprinkled over a tablespoon of applesauce, yogurt, pudding, or liquid nutrition substance. Consume the food drug/food mixer immediately without chewing. Do not store for future use. Special population, pediatric में safe and effectiveness of pimavanserin has not been established in pediatric. Geriatric में no dose adjustment is required. Majority of the patients that they have taken are already geriatric group में ही आते हैं. Hepatic impairment में no dosage adjustment is recommended in patients with hepatic impairment. Renal में no dosage adjustment. Pregnancy and lactation में there is insufficient data on pimavanserin used in pregnant women that would allow assessment of the drug associated risk of major congenital malformations or miscarriages. Adverse reactions, majorly rash, reactions, angioedema, tongue swelling, tightness, dyspnea, वो report किए गई है. Other adverse effects were somnolence, falls, agitation, aggression. Contraindications, patient with a history of hypersensitivity reaction to pimavanserin, cardiac arrhythmias, because it again increases your it causes QT prolongation. So if you have cardiac arrhythmias, that becomes a risk factor. Bradycardia, hypokalemia, hypomagnesemia, all of these becomes risk factors and contraindications. Not approved for treatment of patients with dementia who experience psychosis unless their hallucination and delusions are related to Parkinson's disease. 2023 में they tried to put a FDA approval for using pimavanserin in dementia patients who have psychosis. They did not get the FDA approval. So currently dementia में नहीं use होता है unless the dementia is associated or related to Parkinson's disease. Drug interaction, again CYP3A4 is the one that we have to majorly look for. Concomitant use of drugs that prolong QT interval, obviously it increases QT, it causes QT prolongation. So the drugs that will cause QT prolongation should be avoided. Antipsychotic medications should be, other antipsychotic medications should be avoided with pimavanserin, is because it is not acting on your D2. Why do you want to give another antipsychotic which is acting on the D2? the entire point of using pimavanserin will be disrupted. He highlights pimavanserin in Parkinson's disease psychosis, movement disorder society. This is one of the major society for all of your movement related disorders. Showed pimavanserin as clinically useful for the treatment of psychosis in PD. Canadian guidelines for Parkinson's disease in 2019 showed that pimavanserin could be considered. A lot of these are again from the study. Sensitivity analysis of study has showed decreased risk of falls and fractures in patients with Parkinson's disease psychosis on pimavanserin. Summary में it has US FDA approval for delusions and hallucinations associated with Parkinson's disease. So PDP mainly for delusions and hallucinations. Dementia के लिए US FDA approval नहीं मिला है. The approval is only present in US. European Society, European Union has said that you could consider it. But if you look at all the molecules, clozapine comes at the top in reducing symptoms, then comes your pimavanserin, and then comes your quetiapine. So if we are not talking about the adverse effect or side effects, clozapine becomes the major molecule that could be considered for Parkinson's disease psychosis. The secondary molecule that is usually used or an alternative is quetiapine, and a majority of the expert take that has been, or the expert commentary that has been happening on this is, instead of quetiapine being the alternative molecule, pimavanserin should be the alternative molecule. And once pimavanserin becomes the alternative molecule, we can't use clozapine because of the discontinuation and adverse effect. So de facto pimavanserin becomes the main molecule to be used for Parkinson's disease psychosis. Atypical antipsychotics, again whatever I've said. Thank you.